Okay. Good afternoon, everybody. Today is October 3rd. We are going to talk about the lecture number 4, and we will talk about the cardiovascular system. Thank you for joining us here, Sarah, right? And
Yes.
we are going to start our lecture of today. So let's start. So the topic today is about the cardiac cycle. And talking about cardiac cycle, we just need to remember that we have 7 phases, seven phases of the cardiac cycle that we are going to go in a few moments. Okay, so first of all, cardiac cycle, we will review the physiology of the cardiac cycle, and we will describe the sequence of all the events that will going to occur during the contraction and relaxation of the heart. So at this moment, what I would like is to start thinking, what is the definition of cardiac cycle? In the PowerPoint, here we define that is the group of mechanical and electrical events in the heart. So that is a general description. But we need to remember what is happening. What we need to think, what is happening in every heartbeat. First of all, I would like to go over general rules. Let me see if I can change this. Okay, general rules. Talking about general rules, I would like you to focus on to observe chambers, valves, and think about the flow. Just remember, we have we are going to start from simple, and we are going to start to getting more elaborate. We have 4 chambers. This is the heart. We have 4 chambers, 2 atria on the top, and 2 ventricles below. Then we have 4 valves, so 4 chambers and 4 valves. The 4 valves, the atrioventricular, the tricuspid and the mitral, and we have the semi-lunar valves that are the pulmonary artery and from the aorta. So we have 4 chambers, 4 valves. Remember, to understand the cardiac cycle, we need to remember that the valves are having a function that they are unidirectional, so they will allow flow only in one way. Then talking about the flow, if you see here, is going to go from the top to the bottom. In both, the upper chambers are going to drain blood into the lower chambers. So we have 2 go to 2. So 2 atriums flow are going to go to the 2 ventricles. And, and first of all, talking about flow, the flow passes first to the atria, and then passively is going to flow into the ventricles. Now, when the ventricles are almost full, the atria is going to contract. And that what it's going to do is to push as much blood possible into the ventricles. Now the ventricles now are almost full, and we are going to see that there is having a lot of pressure inside. It's just then that the ventricles at this time are going to contract and push blood out of the heart into the arteries. So what I just described is what we call a cardiac cycle. In simple words, we describe the chambers, the valves, and the flow. So with that, you can describe what is a cardiac cycle. So what is a cardiac cycle in general? The cardiac cycle, and if you can write down this, it could be it's like a summarize all what is a cardiac cycle, are the sequence of events, including pressure, volumes, and electrical changes that occur in a single heartbeat. So there is 3 components that we are going to see today in the cardiac cycle. Pressures, so how the pressures of the atriums and the ventricles and the arteries are going to change in every single phase of the cardiac cycle. The volumes, you already know that we have the flow from one place to another place, and that is going to make space for more blood coming into the heart through the IVC, through the superior vena cava and the pulmonary veins. All right, so in conclusion, we have that the cardiac cycle are the sequences of events, including pressure, volume, and electrical changes in a single heartbeat. All right, so one thing that we need to remember is, remember is the average beats per minute. It's about 70 to 75. So, but the normal range, you know very well, is 60 to 100. But here we are going to having some numbers that are going to be easy to handle. So we have that if you take your heartbeat, your pulse, it's going to take about 70, 80, 90 beats per minute. So that means that every beat is a little bit lower than 1 second. So every lap, every heartbeat is going to take less than 1 second. It's about 0.8 to 0.9 seconds. We can say in milliseconds is about 800 milliseconds. That is going to have a very important connotation when we are going to talk about EKGs. Then we have that how the times are between the systole and diastole. Systole contraction, diastole relaxation. The systole is going to be 1/3 of the diastole. So mostly we have more diastole, more filling than ejection time. So that is about 30% of systole, and diastole is going to be 60%. Just to give you why is important about this is this. You know that the coronary arteries are going to give blood supply to the myocardium, correct? So if you are in resting stage, your systole is going to be 1/3, and the diastole is going to be 60% of every heartbeat. But when you have a coronary artery, some plaque or some blockage, when you are doing exercises or when you have some emotions, your heart rate is going to increase. And that is the time where a person who has a coronary problem can have an infarction. Why is that? Because the coronary arteries that are coming out from the aorta, the coronary arteries coming out directly from the aorta, the coronary arteries will fill of blood when the heart is in diastole. So mostly the coronary arteries will be filling in diastole. So, but when you are doing exercise or you have emotion, somebody get upset, the heartbeat starts to increase in rate. So when that happens, the systole is going to take more time than diastole. So systole is going to be faster. The first heartbeat is going to be faster, and diastole, the filling of the ventricles are going to diminish in time. So as a consequence, the coronary arteries are going to have less volume of blood coming into the myocardium. So that's why a person who has a coronary problems, when get upset or exercises or some emotional distress, that is the moment they can trigger out a heart attack. Okay, so saying that example, we need to talk about some another general rules. In diastolic phase, the AV valves are going to be open. And I put this A and A just to remember what is open easily. Diastolic are going to open the AV valves, the AV valves. And in systole, the semilunar valves are going to be open. So that is actually something that we are going to use in the next slides as definition of description of the phases. Now, another thing that we need to remember that the pressures on the heart are going to change. During systole, the pressures are going to be higher in all cavities of the heart, and the diastole the pressure is going to be lower in all the chambers of the heart. The difference between pressures on the right side and the left side of the heart are going to be about 3-to-1, 4-to-1. Higher pressures we have in the left side of the heart, and lower pressures we have in the right side of the heart. So those are general considerations that easy to remember, and we are going to go over new topics. All right. So one thing I want just to let you know is that even that we know that the atrium also contracts and relaxes during the cardiac cycle. Again, if the atriums, we know that atriums relax and contract in the cardiac cycle, the ventricles are the primary, the ventricles are the primary pumps of the heart. Therefore, the term systole refers to the contraction of the ventricles. And the term diastole refers to the relaxation of the ventricles. So when you are talking about systole and diastole, we focus on the primary structure that produce this ejection and feeling are the ventricles. So when you talk about systole, it's about ventricles. When you talk about atriums. When you talk about diastole, we're talking about the ventricles. All right, so during the relaxation of diastole, the pressures within the heart are low. And here is where the blood flows passively from the atria to the ventricles. So we have the ventricles, the pressure and the volume increases. So it's because of the flow coming from the atrium going to the ventricles, the pressures of the ventricles are going to start increasing. At the end of the diastole, where the heart is totally relaxed, the ventricles, is where we are going to have almost full amount of volume of blood in the ventricles. So this is called the end diastolic volume, the end diastolic volume. End diastolic volume is actually the total blood volume that the heart, the ventricles are having at the end of the diastole. Now, during the ejection of systole, the pressures within the heart are higher. Meantime, in the diastole, the pressures are going to be lower. At the end of the systole, when the heart is ejecting all the blood, the ventricles have empty most of the volume. So we remember that at the end diastolic, we have the end diastolic volume that is going to be about 120 mLs. This 120 mLs, the blood is going to eject, the ventricles are going to eject about 70 mLs. So the number we need to remember that at the end of or after the ejection, there is still blood that is not ejected from the ventricles, and that volume is 50 mLs. 50 mLs. 50 mLs. Another thing that is interesting, that the atriums actually can accumulate maximum about 70 to 80 mLs. Meantime, the ventricles can accumulate between 120 and 140 mLs. So it's actually double of the volume that we have in the atriums. Okay, so let's talk about now about what is next is talking about the cardiac cycle components. Let me see, let me take this out. Okay, and here we have the 7 phases. Here we have the atrial contraction. We are going, so first of all, I want to tell you, all what is in green is systole. Everything that is in blue is diastole. Okay, so we are going to start with the atrial contraction. Atrial contraction. So imagine the contraction of the atrium. Then we have the isovolumetric contraction. We are going to explain that in detail. But first of all, isovolumetric means iso means equal or the same. Volumetric means volume. So there is a contraction, the contraction of the ventricles start, but the volume is not changing. So there is no entry or exit of volume from the ventricles. That's why it's called the isovolumetric contraction. So iso equal volume. The volume is not modified. Then after the isovolumetric contraction, we are going to have the rapid ventricular ejection. So the heart starts to depolarize, and all the strength is going to be ejecting the blood very strongly at the beginning. But then after that, the ventricles start to relax. And this relaxation is going to continue continue the ejection, but is going to reduce the volume of ejection. At the end, here in the isovolumetric contraction, we will have 120 mLs. They are going to eject between these two 70 mLs out of the ventricles. The rest is going to be staying in the ventricle, 50 mLs. Then after the systole happen, the heart starts to relax, and the pressures are going to start changing. And the pressures are going to, for example, decrease in the aorta, is going to increase in the atriums, and what is going to happen that the valves are totally closed. The 4 valves that we mentioned at the beginning are going to be closed. And that volume is going to stay same in the heart. That's why it's called isovolumetric relaxation. So the volume is not going to, when you said isovolumetric, means that the 4 valves are closed. The 4 valves are closed. Then when you have the isovolumetric relaxation, here we have the rapid ventricular filling. Why? Because the atriums meanwhile were accumulating blood in the atriums, and that is going to increase the pressure in the atriums, making opening of the atrioventricular node, atrioventricular valves, and having a rapid ventricular filling into the ventricles. Then the atriums are not going to have the same amount of volume because it was draining to the ventricles, and the pressure of the atriums are going to be reduced. So the flow from the atriums to the ventricles are going to start decreasing. It's going to start filling the ventricles, but the volume and the flow that is coming from the atriums are going to be reduced. That is what we call the reduced ventricular fill. And then the cycle is going to end into the atrial contraction to continue with the cycle that we have here. So in conclusion, we have 2 isovolumetric contraction and relaxation. Atrial contraction sounds like it's systole, but we was talking the systole is related to the ventricles. And isovolumetric contraction, rapid ejection, and reduced ventricular ejection are these the one related to the ventricles. This atrial contraction is going to provide extra volume of blood into the heart. When you have the atrial contraction is going to give about 40 mLs additionally to the ventricles. So we are going to talk that in details. So now here we have this is the cardiac cycle. Here in red we have the ventricular pressure. So the variation of the ventricle pressure during the cycle. Here we have in this area, I'm sorry for this, here we have in this area, that is, all this is the atrial contraction area. Then is coming the isovolumetric contraction. We have the ejection. Ejection is rapid and reduce ejection. Then is coming the isovolumetric relaxation, the rapid filling. The diastasis is the same to say the reduced filling of the ventricles. And here we have the atrial systole. This area is similar to this. So again, just remember the word air. Air, A-I-R. Air is atrial systole, isovolumetric contraction, start with contraction. So remember contraction, we have relaxation here, right? So you start with C. C is the first letter of the alphabet. So you start atrial contraction or atrial systole. Then we have the air, isovolumetric contraction, and we have the rapid ejection, air. Rapid ejection, and then this portion is going to be the reduced ejection. Then, after the ejection happen, is going to have the isovolumetric relaxation. Again, rapid inflow or rapid filling, and diastasis is the slow filling of the ventricles. And then the atrial contraction start again. For the last time, atrial contraction, isovolumetric contraction, we have the rapid ejection, ventricular ejection, the reduced ventricular ejection, then the isovolumetric relaxation, rapid filling, reduced filling, and the atrial contraction start again. Okay, so let's start with the phase A. But talking about the phase A, we need to just remember that the heart is a pump that circulates blood through by two different but interconnected vascular systems. During one cycle or cardiac cycle, all four chambers go through two basic phases, through systole and diastole. Now, each cycle is initiated by a spontaneous generation of the action potential of the SA node. The action potential then travels through the AV node into the ventricles. All right, so the graphic that we just saw is going to help us to analyze the cardiac cycle in four components. We are going to talk about in each cycle, in each phase, the 7 phases that we mentioned, what happened with the heart. Then what happened with the pressures and volumes in the cavities. We are going to correlate with the EKG, and then we are going to correlate all together with the sounds. We know S3, S4, we are going to know what is S3, S4, S1, and S2. Okay, so heart first, pressure, volumes, EKG, and sounds. So let's start with the atrial contraction. In the atrial contraction, what we are going to see is that we have the atrioventricular valves open. If you see in the picture, then the two semi-lunar valves are going to be closed. So meantime, the atrium is receiving blood from the IVC and the superior vena cava, and the left atrium is receiving blood from the pulmonary veins. So these atriums are going to start filling up of blood, and when they are totally full of blood, the SA node is going to start depolarizing the chambers. We are going to see in addition that, for example, in this atrial systole, contraction, the atrium is going to have about 4 millimeters of mercury. You don't need to remember those numbers, it's just to make an example. The other atrium, as you can tell, the left side is higher pressure than the right, the left side is higher pressure than the right always. And then we have here the some examples of pressures. For example, 10 in the left atrium, and the left ventricle is going to have 8 only, so it's lower. Meantime, on the right side is 4 versus 0. So that's how the pressures that are increasing because of the venous return and the pulmonary veins into the atriums are going to make increase the pressures of the atriums and make it higher than the ventricles, who they just eject all the blood. So they don't have blood because they just finish the ejection. That's why the volume and pressure go down, and the pulmonary and the pulmonary and the aorta valves are going to be closed. Why? Because the blood here is going to make more pressure, higher pressure than the ventricles. So higher pressure from the arteries and the ventricles may close the semilunar valves. And here the pressures of the atrium, who was receiving a full of blood, are going to have higher pressure from the atriums going flow to the ventricles. So that is how is happening the atrial contraction. Here we have that as we just said, in the ventricles there's a remnant of blood that is about 50 to 80 cc. 50 to 80 cc. Depends on the size and the gender of the person. And what is going to do this contraction of the atrium is doing this. It's going to bring an extra 40 mLs. When the heart is going to, the atrium is going to contract, this atrial contraction is going to provide 40 mLs in addition. So total we have 120 cc. 120 cc. So that is about the volume of blood that we found at the end of the atrial contraction. So the ventricles at the end of the atrial contraction, the ventricle volume reaches its maximum volume capacity, and this 120, 40 plus 80, 80 was from the previous cycle, plus the contraction of the atrium bring more blood. 120 is going to be the end diastolic pressure, the end diastolic volume, sorry, the end diastolic volume. So total is about 120. What happened, and that is what we call the preload. Preload. Preload is the venous return, is the charge or the load or volume that the ventricles are going to have, or that the atriums are going to bring into the heart. So preload is the volume that is going to be eventually ejected in the next cycle. All right, so during the atrial contraction, what happened is that the atrium starts to depolarize, so the pressure of the atriums are going to increase. And this produces the AV valves to open. What happened at the beginning is going to be a rapid atrial blood flow movement into the ventricles. What happened with the vessels? Remember that. Remember here that the vessels, the veins, the IVC, the superior vena cava, and the pulmonary veins, do not have valves. Why? Because they are coming by gravity into the atrium. The inferior vena cava, because of the thoracic negative pressure, is going to work as a vacuum and is going to bring the blood. So these veins do not have valves. So they will have a small increase in pressure here when the atrial contraction, when this atrium is going to increase or contract, the pressure increase. So there is a little bit of reverse flow into the pulmonary veins and into the superior vena cava and to the IVC. So what happened is that we have what we call the A. You see this line here? This is the venous pressure. We have A, C, and B. So the A pressure is when the atriums contract, and this contraction make the flow going towards the IVC and the superior vena cava and the pulmonary veins. But it's minor. But that means an increase of venous pressure. When you have a catheter and you put it through the cephalic vein or basilic vein, you go into the axillary vein, go to the subclavian vein, brachiocephalic, and they go drain here a catheter to measure the pressures of what we call the central vein pressure. And that is what actually A represents. So you remember when somebody has a problem with a heart failure, for example, these pressures are going to increase. So there's backflow into the jugular veins. So that is what we call the jugular veins dancing. So, so when it's important to make the remark about the pressure, the central vein pressure, because that is how in ER we control the patients directly to have some fluids, especially to know how are the pressures in the heart. Okay, so in the EKG, you are going to hear the S4. What is S4? S4 is the sound. If you see here, S1, S2. S1 is lop, dop, lop, dop. First is the atrioventricular valves close, and then the semilunar valves close. But before that, you can hear what we have, the S4. S4. S4, it can be here in the heart. And who produced the S4? S4 produced by the rough flow from the atriums to the ventricles. That is what is S4. Okay. All right. So and this can be heard. Mostly we don't hear the S4, but when you can hear the S4, that is because patients mostly they can have hypertrophy of the right ventricle or the left ventricle. So that is about the contraction of the atrium. So in conclusion, we have the atrial contraction. During this phase, the atrium is going to go over a contraction and develops increased pressure. So that is going to reestablish some gradient of pressure difference between atrium and ventricle, making the blood flow from the atriums to the ventricles. All right, so when at this moment we have that the atrium start to contract, depolarize, and that is the moment where the ventricles are starting to depolarize. That is going to lead into the next phase, that is the isovolumetric contraction. Let's go over the isovolumetric contraction. And here, the isovolumetric contraction, we will see that there is some events that happen. First of all, if you see here in this picture, the isovolumetric contraction are going to make close the all four valves. The four valves are closed. So there is no exit, there is no entry of blood into the ventricles. Just giving some examples, the pressure of the pulmonary arteries is about 25, and the pressure of the right ventricle is going to be 20. So this pressure is higher than the ventricle, so this valve is closed. We have 100 millimeters of mercury in the aorta, and we have 80 millimeters of mercury in the left ventricle. So that's why these valves are going to close. We have 4 here and 10, and you can see these 4 cannot open the atrioventricular valves because in the ventricles are higher pressure than the atriums. Okay, can you hear me, right? Sarah, can you hear me?
Yes, sorry, I can.
Okay, so yes, yes, so sorry, the machine was telling that was disconnected. Okay, so that is the isovolumetric contraction. When you talk about the isovolumetric contraction, we have from the previous cycle, from the previous phase, we have that we already have 120 cc. So this pressure was higher in the atrial contraction. Meantime, the ventricles are going to start contracting, increasing the pressure on the ventricles, matching the pressure of the atriums. So these valves are going to be closed. So that is, there is a moment that the pressure is still increasing, but this pressure is still not so high, is not higher than the aorta and the pulmonary artery. So that's why everything is a closed environment here. So then after this, you're going to see that that is represented in the EKG as the QRS. QRS. So isovolumetric contraction is the depolarization, is what we call the early systole of the of this phase. So here is the QRS, and here because the first of all the atrioventricular valves are going to close after these pulmonary semilunar valves, that is going to produce a sound called the S1. It's the lop of the heartbeat. So QRS is isovolumetric contraction. S1 is the where you can see hear the sound. Let's talk about now the next one is the rapid ventricular ejection, and let's go here. So the ventricles start to depolarize, and they are going to start to contract. The contraction. This contraction is going to make ejection of the blood from the ventricles to the arteries. So right ventricle to the pulmonary artery, and left ventricle to the aorta. I put it in dots because the aorta runs behind is posterior to the pulmonary artery. Then we have here that the pressures, because of the intense contraction of the ventricles, are going to be higher than the pressures on the atriums. So here we have some examples. Let me see. Okay. So in conclusion, here we have the pressures are higher in the ventricles than the atriums, and the pressures of the ventricles are higher than the arteries, pulmonary artery and aorta, and the ejection is going to happen. So this ejection is represented by the ST segment. If you see QRS, P is the contraction of the atrium. The PR segment here is the ejection of the atrium into of the blood into the ventricles. Then here we have the QRS is the depolarization or contraction, the contraction of the ventricles, and this ST here is where the ejection is going to occur into the arteries. So in this ejection is going to pass 70 mLs, leaving about 50 to 80 mLs in the heart. So that is what we call the ejection fraction. So if you have 120 in the ventricles and is ejected only 70, you need to know how much percentage is 70 from 120. This percentage is the ejection fraction that we can measure with catheters. This ejection fraction normally is between 55% from up to 70% of the whole volume. So, for example, 120 mLs, we eject 55% of that volume up to 70% of that volume. That is a normal ejection fraction. This ejection fraction is going to be abnormal when you have, for example, heart failure. Okay, so in the EKG, we already know that is the ST segment, and there is no sounds at this moment. And as a conclusion is the phase during which blood is being actively expelled from the ventricle chamber to the artery. All right, so let's go to next phase is the reduced ventricular ejection. So all the strength at the beginning of the ejection is a strong ejection, but then the heart starts to repolarize. So that means to start to relax. So the ejection is going to continue, but in less amount. So if you see here, the arrows are not so thick than the previous one. The ejection is going to continue, but not as much strong as before. So here we have that for the ejection, still ejection, the AB valves are closed and the semilunar valves are open. So this is the beginning of the repolarization when you have reduced ventricular ejection. It's not contracting as before at the beginning, so start to relax. And this is representing the T wave, the T wave. The T wave is going to be represented in the reduced ventricular ejection. Let's talk about the isovolumetric relaxation. And isovolumetric relaxation, what actually we have is all the valves are closed, right? All the valves are closed. In this case, we have that the pressures are accordingly in order not to get open the valves. Ventricle higher than the atriums, and the arteries, pulmonary artery and aorta, higher than the ventricles. So there is no entry or exit of this blood from the heart. This isovolumetric, the pressure of the ventricle is lower than the arteries, and the pressure of the ventricles are higher than the atriums. So that is what we can conclude. So here we have, in this moment, we have about 50 to 80 mLs of blood in the ventricles. Meantime, what is happening? So what is coming after the isovolumetric relaxation, the next one is the rapid ventricular filling, and that is what is coming. Meantime, the atriums start filling with more blood coming, so the pressures start to increase, are going to match in some moment the pressure of the ventricles, and even though it's going to be higher, this pressure, and that is going to create the filling of the ventricles that we see in the next slide. Here we have the rapid ventricular filling, and here we have some examples. So the pressure on the atriums are going to be higher than the ventricles, and that is going to make open the AB valves in order to have the rapid filling. This is actually just a continuous blood without contraction. So the contraction is going to be at the end to complete the cycle. After rapid filling, ventricular filling, we have the reduced ventricular filling, and after the reduced ventricular filling, we have the atrial contraction. In this case, there is no contraction yet of the atriums, and that is going to bring blood into the ventricles. Okay, so we have the reduced ventricular filling here, and if you see here in the AKG in the what is in the isovolumetric relaxation and rapid and reduced filling, always is going to be after the T wave. They are going to be the isoelectric wave. So there is no elevations, there is no depressions. So you can tell here that the first phase is the atrial contraction, P wave. Then we have the isovolumetric contraction, is the QRS. Then we have the ejection here in ST, and then we have the T, that is the relaxation of the ventricles, and this is the diastole. So from here to here is going to be for here, including the T, because we have on the under T wave, we have still the reduced ventricular ejection. So from P to T is systole, and this isoelectric is going to be the diastole. Remember that the QRS, we have here the contraction of the atrium, and the relaxation of the atrium is going to happen simultaneously with the QRS. But the QRS is from the ventricles are so strong sign that the wave of the atriums are being hidden. It's not seen because it's covered by the QRS. So in conclusion, we have systole P, QRS T, and the rest is the systole. All right, so let's talk about the venous blood, and I'm going to download this after we finish the session. Here we have the pressures. One important thing for ER is to know the pressure, the central venous pressure. And here we have the 7 phases, A, B, C, D, E, and F. And we have the waves of if you see here, A, C, and B. At what time, at what moment are going to increase these pressures in the atria? Are going to be in the atrial contraction, in the isovolumetric contraction, and the isovolumetric relaxation. Just remember, the central venous pressure are going to increase in the isos, in the isovolumetric contraction and the isovolumetric relaxation. And of course, in the atrial contraction is where definitely the atrium is going to increase. The ventricles are going to increase pressure in the first 3 phases: atrial, IB contraction, and the rapid ventricular contraction. So here, this is the pressure of the ventricles going up. So we have here in the atrial contraction, isovolumetric contraction, and then we have the rapid ejection of the ventricles. Then the pressure starts to go down. So that's why I put graphic here. The aorta is going to be in the rapid ventricular ejection. If you can tell, the ventricular ejection is going to fill the aorta with a lot of blood. So that's why that is the moment where the blood pressure or the pressure on the aorta are going to increase. And we have the relaxation here. When the heart is going to relax, the volume is this is the aorta in green. So the aorta starts to increase the pressure, but at the moment where the isovolumetric relaxation happens, the B valves are going to be closed, and the semi-lunar valves are going to be closed. But that is because of the elasticity of the aorta is bringing back, it's trying to bring back blood into the ventricle. That is why we have a small increase of the pressure at that moment. And that is what we call the dicrotic notch, that dicrotic notch. Here we have the, what is the dicrotic notch? Let me see here. So in general, that is the dicrotic notch. All right. So I will give you this video. I think we don't have the time yet, but is this video I'm going to download, and please, yes, I would like you to see this video because that is going to give you all the summary of what we was talking. Okay, you still having time, Sarah? Or
Yeah, I have a few more minutes.
okay. All right, so let's go over the, here we have the regulation of the arterial blood. So let's go a little bit quicker here. We have the baroreceptor. Baro means pressure. Receptors are some receptors that are located in the carotid sinus, carotid arteries. Then we have the renin, angiotensin, aldosterone, what we call RAS, R-A-A-S, the RAS. And we have the central and peripheral chemoreceptors, and that are located too in the aorta. We have the ADH, the antidiuretic hormone, and the atrial natriuretic peptide, the atrial natriuretic peptide. This atrial natriuretic peptide is going to be released by the atrium, especially the right atrium. So all these guys, what they are doing is try to regulate the blood pressure. For example, if you have baroreceptors, the baroreceptors are going to stimulate the sympathetic and the parasympathetic. This sympathetic, sympathetic produces adrenaline, noradrenaline is going to produce vasoconstriction. It's going to increase the blood pressure. These baroreceptors can activate the parasympathetic system. And the parasympathetic system release the acetylcholine. And the acetylcholine effect is to decrease the heart rate. So if you decrease the heart rate, you decrease the blood pressure. Why? Because blood pressure is equal to the cardiac output multiplied by the peripheral resistance. But cardiac output is related to volume by the heart rate. If you decrease the heart rate, you decrease the cardiac output. If you decrease the cardiac output, you decrease the blood pressure. So that is how these baroreceptors are going to happen. If you have too high blood pressure, baroreceptors, receptors of pressure, are going to detect it. So that means you have hypertension. So what is going to do? It's going to stimulate the parasympathetic to release acetylcholine, decrease the heart rate, and decrease the blood pressure. If the baroreceptors detect low pressure, the baroreceptors stimulate the sympathetic, and that produce a release of adrenaline, and of course increase the heart rate and increase the contractility of the heart, increasing the blood pressure. The renin-angiotensin-aldosterone are going to be the renin produced by the kidney, angiotensin by the liver and the lungs, and aldosterone by the adrenal gland. So when you have low blood flow, perfusion into the organs, for example, the kidney, if you have low blood pressure in general, the kidneys will not receive enough blood supply. So that is where this is going to be detected. And when you have low blood pressure, the renin is released, increasing the angiotensin, aldosterone produces retention and reabsorption of sodium, increasing the volume of the blood. That means increasing the cardiac output. If you increase the cardiac output, that increase to the blood pressure. We have the central and peripheral chemoreceptors. That is going to be related to amount of carbon dioxide. We are going to see that. ADH, antidiuretic hormone, reabsorption of water, and atrial natriuretic peptide is when you have, for example, when you are going to have too much high blood pressure or blood pressure, that is the ANP is going to eliminate sodium, and that is going to decrease the blood pressure. So there is many mechanisms of blood regulation. That is baroreceptors, presoreceptors, the RAS, the central and peripheral chemoreceptors, and the ADH and the ANP. Okay, so I was trying to summarize this. I will give you the, let me see, just a moment. So I will give you the full, the new PowerPoint. Is very well classified. So I think you will enjoy it, and I will say thank you for your attendance. If you want, we can do extra time in another moment in order to go over what is AKG. But definitely what you need to focus for this class is about arrhythmias. The most common are going to be the atrial flutter, and the other one is the atrial fibrillation. Few words about this is the atrial and the flutter are going to be easily to differentiate. If you see the atrial fibrillation, where is the P wave? It's very tiny, tiny, tiny. Meantime, the flutter, we have very high P waves. So that is what causes atrial and flutter? Mostly coronary ischemias. So when you have some coronary blockage of plaques that can produce ischemia on the myocardium, that could be the beginning of atrial fibrillation or atrial flutter. Okay, Sarah, thank you so much for attending. I will send the PowerPoint in the next few minutes. Any questions?
Okay, are you going to post the PowerPoint on Moodle, or are you going to email it?
I'm going to put it in the Moodle.
Okay, perfect. I'll download it from there.
Okay, so I hope you enjoy it as much as I enjoy it, and I will see you in the next webinar. Thank you so much.
No problem. Always a pleasure.
All right, gracias.
Have a good night.
Good night.